So if you have any last minute letters that need to get to Santa, I know where wife works.
Hi.
How are you?
Good.
Hi there.
How's it going? I
Great.
like your art in the background. That's
Oh, thanks. I just realized it's crooked. There's a wall in my office that doesn't have some bright art ones, so it's kind of tough to turn that on and see if it works.
Just make sure this doesn't.
I'm
yeah,
Sharon. I'm from CE Zoom.
Sharon. I'm Susan. It's nice
Nice to meet you.
to meet you. I'm not even sure why Kim wants me on this, but somebody's got to be the arm candy around here. Could be you.
No, it's you got to be the eye candy around here. So,
Oh, right? Just kidding.
all right. Let's see. It looks like Laura's on her. She's muted though.
Hi, thank you. You're welcome. I didn't go in and go through and call us if you need us again. Okay. All right, we'll see you next week.
What is that? That's a cool typewriter.
I think Laura's muted. I don't. Can you hear
Am I
us,
muted?
Laura? Nope, Kim, we can hear you. How are you?
Hi.
Oh, hi,
I'm good. How are
Laura.
you doing?
Good.
Kim,
Yep. Hey, Susan, how are you doing?
I'm well. How are you?
Is it better with the light on me or the not? I guess it's better with the light. Okay. Just checking. Okay. I'm good. How are you all doing?
Good.
Wow, this is, we've got a lot of people signed up. This is amazing.
You have a ton of people signed up. It's great.
Yeah. It's, I think, a very timely and relevant topic that we should have a lot of people signed up for.
That is great.
Hmm.
591.
Wow.
Ooh, that's
I was
amazing.
really hoping for 600.
Hey, there's still like 15
You never
minutes.
know.
I know.
And we do have Dr. Susan Maples on this program, so there's a good chance we'll get it.
What are we getting?
600 attendees.
Please. How many do you have?
591.
Isn't that so weird in the middle of the day? This is obviously quite topical.
Yeah, exactly right. I think that tells you how important this topic is.
Jenny, you cannot get COVID through Zoom. I hate to tell you that. It does not travel through the computer.
That is not what I've read, Susan.
Yeah,
I will tell you,
we're gonna talk
in
about
Florida,
virtual-
I just saw a woman lying in a bikini with a mask on, as if it's coming right off the ocean, all by herself. And I was thinking,
Oh,
might be
Oh,
expecting company.
honestly, I have two people beside me, so we
Oh.
are all wearing masks. So I have
Got it.
two people in the room with me. So
Got it.
Otherwise it's the virtual aerosol. You know, you gotta worry
Right.
about
There you go.
it.
The way I see it, it's we're going to get our immunity through virus or vaccine, whichever comes first. Hopefully vaccine for me.
Hopefully for all of us.
here's
I'd
Bob.
like to introduce myself. I'm Bob Cantrell.
Hi,
I know
Bob.
everyone except Susan.
Nice to meet you. Thank
Nice
you.
to meet you too. Sharon, is this a record for people coming on Zoom, CE Zoom?
I mean, for a private course in the middle of the, or excuse me, a public course in the middle of the day, like fantastic attendance. Like sometimes we'll say like 200, but yeah, it's great. So, night courses do really well also because people aren't working. I did a CREST course last week. It was city specific, so it was New York City, and we only had 3 people on.
Oh, wow.
Yeah, and I was like, oh, they're not going to be happy about this, but it was in the morning, like on a work day.
Okay. All right, I'm going to
But
sign off.
this is
I'm
great.
not gonna say any more the rest of the day.
We
So
had the
Jenny-
American Dental Association early breathing conference this week. There were only 4 of us speaking, a pediatric dentist on Thursday night, general dentist, an ENT and an orthodontist. And it was so incredibly well attended. And I just read through 22 pages of briefs and people were like, best ever Zoom conference. And I'll tell you what really made it hum was we all had about 90 minutes and then 15 of Q&A. So it was intensive, but then in the end, we all had 1 hour breakout session where people could go anywhere they wanted and you could see their faces and they could ask you questions directly and you could interact.
Aw.
So nice. It was great. I think I had 30 pages of people on my call though. So it was a little weird because people just pop up and they're like, oh, introduce themselves. It's fun. Fun to meet attendees. At least you feel like you
Yeah.
meeting some people.
I think the virtual webinars have been really nice because, you're in a big conference room. If you have a question that it's probably not going to get to the speaker, and this is like a lot more, although it's virtual, I think people can ask questions and they get answered a lot easier than they would at a conference, a live conference.
I have a question before we get started and everything.
Mm-hmm.
Is, as far as at the end of this presentation, it was my understanding that we will invite people to stay on a little bit longer should they want to listen to Kim and Susan speak in more detail about DAX. Is that correct?
And DAX is a product.
Right.
Yes.
Okay. So yes, so what you'll do your CE portion, all education, your Q&A, and at the end of the Q&A, I'll put up the verification slide and you can read it. And then you just have to state that the educational portion is over. So if you want, how long is your presentation, Kim?
Oh, it's probably 50 minutes.
Okay, so then save the last 10 minutes for Q&A, and you, Jenny, or you or Laura are going to field the questions. Correct?
Mhm.
Okay.
And maybe Laura, will you do it this time since I have a mask on and it's hard
Yes.
to? Okay, thank
Yes.
you.
Okay.
Mhm.
Yeah. So do like 10 minutes of Q&A, and then you just have to state that the educational portion is over, and we'll put up your verification slide, and then you can say, we'd love you to stay. We're going to talk about this.
Yeah, Yeah.
Yeah.
okay.
Great.
And
I'm going to go wheel one of those babies in here just in case I feel like getting
Oh, cool.
cozy with it.
nice. I'm gonna go grab a pen.
All right. And Kim, you know how to share your screen and all that fun stuff,
Yep.
correct?
Yep.
Okay.
Yep.
Okay.
This is from Horton Here's a Who. At first we were thinking the Cat in the Hat, the picker upper, 'cause sometimes my hair just flies right in. But, I should get our little elf because today our little
Elf
elf
on the shelf.
is sucked in there. I could actually pull that out of here. It would be very funny.
That would be funny, actually.
I'll do it. It's really good.
Elf on the shelf.
So
Why
Jenny,
didn't I think of Elf on the Shelf? I mean, geez, everyone does it.
My little elf, if this is on, you just get sucked right in. And all you can see is this little hat.
Right.
I can go, oh my gosh, look.
I think too close.
Do it.
I'll
The
bring the
elephant's
humor,
getting
you bring the content. I'll spice it up a little bit for you, Kim. But no, I feel like I could speak not in an advertisement mode, but in the idea of the various things that we do to reduce aerosol. You have,
Yeah. Yeah,
you're going to be talking about the air sucker. What about the air purifier? I use the molecule. Should I not mention that brand either?
No. I'm gonna mention those. We're gonna look at all those different technologies
Okay.
and their, what they do and what they don't do. Yep, for
And
sure.
I am already getting a lot of emails of people having issues getting logged in, saying that the link won't work.
Okay, let me look at that.
And sometimes it's not a live link, so I just tell them to copy and paste in their browser, and that seems to do the trick for people. But
Right.
if I had the link that I could send to them, I can do that. Hold on
Let me
here.
see. Register. I'll just email you this link.
Okay.
And I'm going to join from my laptop really quickly.
Sorry, guys.
That's okay.
And this.
I don't know how we get so many people in the middle of the day. Don't people work anymore?
Okay, there we go. And did you guys already go through screen sharing and everything, Sharon? So Kim's good to go?
Yeah, Kim, do you want to just share your screen really quickly? Make sure that is working.
Megan?
Oh, I need to turn those notifications off, but I don't know how. I think we're gonna have a lot of attendance because I have not usually have this many emails.
So the link is working. It's just a register with your email, and then they have to click the link below.
That's, yeah,
And it's putting them in a holding room.
Yeah, I followed the link to see what it would do so that I could, respond accordingly.
Yeah.
But some people are saying they don't have the link at all. So I'm replying real quick with the link and they should be good to go.
And if they can always reach out to our tech support too, which maybe I can text her. I haven't seen anything come in. Most of the time it's user error and nothing that you can do about it.
Yep, exactly.
Besides go to their house and do it for them. Okay. So Kim, did you try sharing your screen?
I haven't tried sharing it yet, but I will right now.
try it really quickly
Okay.
and
That work?
yep. And then perfect.
Okay.
So you can stop your screen share for just a sec. That's amazing. All right. And then,
I'm gonna turn my video off just so that
Me too.
I don't have a mask on in front of everybody
okay.
when I'm doing the introductions.
Sure. Do you just want to let attendees know, like, you know, I can do it or you can do it. Just make sure they get the verification code given at the end of the presentation, enter
Yep.
that on their CE Zoom account. Perfect.
Oh, that's okay. We usually don't do the video anyway, so it's fine. Verification code at end. And then, and you have my slides, right, Sharon?
Yeah. Do you want me to put that up right now? Because we're about, okay, if everyone wants to, we can mute our mics and I'm going to start the webinar. And I'll just put that slide up for a minute or two. Okay, let's get started. If Jenny, if you want to start us off.
Oh, yeah, sure. Thank you, Sharon. And thank you everyone for attending today's webinar. This webinar is sponsored by the CariFree Cooperative. And the CariFree Cooperative is a cohort of like-minded dental professionals who are working together to further the message of risk assessment, preventive dentistry, oral and overall health and wellness. Our presenters today are members of this cooperative. They are Dr. Kim Kutsch and Dr. Susan Maples. And I'll pass it off to Laura now to introduce Dr. Maples.
Thank you, Jenny, and thanks everyone for being here today. I have the honor of introducing Dr. Susan Maples. She's an international speaker in the areas of total health, the oral and systemic health connection, and the diabetes epidemic in America. She also speaks in the areas of leadership, team building, advanced case planning and acceptance, relationship-based target marketing, and how to grow healthy kids in your dental practice. When Susan is not practicing dentistry, she serves as a leader in helping her profession take their place in the US health crisis by educating the public on the mouth-body health connection. Dr. Susan has authored the book Blabbermouth, 77 Secrets Only Your Mouth Can Tell You to Live a Healthier, Happier, Sexier Life. And in addition, she is the co-researcher in an award-winning study on detecting diabetes in your dentist's office. Please help us give a warm welcome to Dr. Susan Maples. Thank you for being here.
Thank you so much. It's my absolute pleasure to be part of the CariFree Cooperative and my honor to be on this webinar speaking with my very good friend Kim and with all of you in the middle of the day. I said, my gosh, it's the middle of the afternoon. Doesn't anyone work anymore? But obviously a very, very topical subject today and something that we're all excited to learn more about. Thank you.
We also have joining us a man who needs no introduction, Dr. Kim Kutsch. Dr. Kutsch is a retired dentist of 40 years. He is a prolific writer, thought leader, inventor, and researcher in the field of dental caries and minimally invasive dentistry. He acts as a reviewer of the Journal of the American Dental Association and Compendium. Dr. Kutsch is the CEO and founder of Dental Alliance Holdings, the manufacturers of the CariFree system, and is a scientific advisor of dental caries at the prestigious Cois Center. We are so fortunate to have him as our fearless leader. So please help me in welcoming Dr. Kutsch. And before I give the platform over to you, Dr. Kutsch, I just want to let everybody know that we will be giving the verification code at the end of today's presentation. So stick around. This is going to be a great presentation between Dr. Maples and Dr. Kutsch. So take it away.
All right, thank you, Jenny. Let me share my screen here and we will get started. Oh no, come on. Here we go. So this is a really, really important topic. And I think it's this conversation is long overdue in our profession. And so I'm really happy that we have so many people who've logged on and joined us today for this webinar. Susan and I are going to go through just some of the research, some of the science, and look at some of the things that are available to us to look at in terms of safety, air safety in our dental practices and what we do. Jenny gave me a really good introduction there, and I don't have a whole lot to add to that other than just as a disclosure, I started this year hang on, I'm not advancing. There we go. I started the year like we all did. I think life was pretty normal. And then, this COVID pandemic hit early in March, and we, I looked at closures of our dental practices. And one of the things that in my own history is back in the 1990s, one of the dental companies I started was focused on minimally invasive dentistry. And I developed some air abrasion technology. And one of the things that I developed as a accessory to that was a extraoral HEPA filter vacuum. And so I have a lot of experience and expertise in this particular technology. And so I have two sons. And of course, after you've been in the profession for 40 some years, I mean, literally all of my best friends are dentists and hygienists, and I really wanted everybody to be safe. So I started another company this year and developed and designed a new extraoral vacuum. And I will be talking about that after the class is, the educational component is done today. Another disclosure is that, of course, the CariFree company, I'm CEO of CariFree, and we manufacture a variety of products primarily aimed at treating dental caries, but one of our rinses turns out to have an ingredient that's very effective as an antimicrobial agent against COVID-19 specifically. So That's another thing. I'm not really going to talk about that today, but we will mention pre-rinses for a second, and you just need to be aware of that. And Susan, if you want to give just a little more personal history about yourself.
So personal history, I have a passion for total health dentistry, and that includes building a practice of distinction in the marketing arena around total health, so that I'm attracting people from about 100-mile radius. That's our hope. We don't like it when it's a lot further than that. We do get a lot of people who fly and drive in, but about 40% of our patients are referred to us by the medical community. So all eyes on us in terms of a practice of distinction around safety, especially with regards to health and to COVID right now. So a lot of people call and ask, a lot of people visit, a lot of people want to know what we're doing. And so I'm very happy that the American Dental Association established a code, D1999, that allows us to charge a little bit to the patients. I believe we have some responsibility to cover a lot of this ourselves, and I would hope that the insurance company would cover some as well, but certainly some of the patient's responsibility as well, since we've added so much to our bottom line. Even gloves has gone up 77%. So when we talk about the things that we're doing to help care for our team members and our patients and establish a practice of distinction, it is my pleasure to share with you some of the things we're doing in regards to kind of tackling the aerosols that we live in. We live in what I call the splash zone. So yeah, my real passion is for just helping people take one step further toward health every day. And fortunately, my 10 team members and I have avoided COVID, and I hope that you have as well. But it's definitely a high risk arena. So happy to be here.
Great. So we are still in the midst of this pandemic, and here's the map from last week. In the United States, we're in that huge third wave that's going on right at the moment, and we've got record numbers right now of hospitalizations, record numbers of new cases every day, and record numbers of death, and literally throughout the entire United States. Of course, this is going on globally. When we talk about our dental practices, we have guidelines that have been issued by the ADA, the CDC, OSHA, and then our own state health authorities as well. All of our practices have been affected. I know a couple of practices that have had to quarantine, that had one of their staff members who became COVID positive and didn't contract COVID at work, but became positive. And so we've got those issues to deal with. Susan mentioned that we live in the splash zone. I call it this biological cloud that we work in every day. And there's other contaminants in the air that that we really haven't stopped to talk about. And that's why I say I really think this conversation is kind of long overdue. COVID was kind of a wake-up call, I think, for the profession. But there's other viruses in the air and bacteria in that aerosol that we live in while we work all day long. Mercury vapor, enamel dust, etc. But there's a lot of contaminants there. A couple of data points that I want to share with you today that I think are really topical, and we should be talking about this right now. This was a study that was published back in 2017, and they looked at the riskiest professions or jobs in the United States. They looked at 947 different jobs. They surveyed 125,000 people, and they were looking for the riskiest job for contracting an infectious disease while you were at work. And number one was dental hygienist. And really, when you stop and think about it, that's not surprising. Number two was general dentist. Number four was dental lab technicians. And number five was dental assistants. So of the 947 jobs they looked at, 4 of the top 5 riskiest jobs in the United States for contracting a disease while you're at work are us. We are at the top of the list. So that's a challenge. And then this is the real story. And you may have never heard of this. I know that a lot of dental professionals have not, but it's pulmonary fibrosis. And this was first reported by the CDC in 2015 when they noticed a cluster of a disease outbreak of idiopathic pulmonary fibrosis in a county in Virginia amongst just dental professionals. And somebody, looked at that and said, wait a minute, this doesn't add up. We've got all these dentists and hygienists here that are, been reported in this study. And so the data turns out that we are 23 times more likely to contract and die from this disease than anybody else. And so the question becomes, well, why is that? And why, we haven't heard about it a lot, but it was just first recognized really about 5 years ago. So this is a conversation that we're going to continue to have in dentistry. It was really represented a tipping point for me this year. As I started working on this technology, I had 2 colleagues die. I was notified on May 4th that 2 of my colleagues, 2 of my friends had died of IPF, both retired dentists. So this is a real disease. And while we don't know a lot about it at the moment, what we do know is that it's progressive, it's untreatable, and it's fatal. We believe that it's caused by the chronic exposure to this biologically active cloud, aerosol cloud that we work in. And it's just pieces, tiny pieces of bacterial protein that end up in our lungs in the alveoli that create the subclinical inflammatory state in the lungs that eventually lead to just fibrosis. Your lungs turn to scar tissue, and of course you can't live without lungs. So this is something I think this is a topic that we need to be concerned about. And that I think after COVID's over, and we've all had the vaccine or we've had the virus, we've been exposed, we have herd immunity, everybody wants to like to go back to normal. I think we need to have a new normal conversation in dentistry, and we really need to talk about these aerosols. So one thing that we do know, this was a study from earlier this year, particularly with COVID-19, what we're currently doing is not enough in terms of protecting ourselves. So the PPE, obviously we upped our level, our standard of PPE. When we look at the air quality in our practices, I mean, the 2 obvious things we talk about in terms of air quality in any building is like the temperature and the humidity. Neither one of those things, unless they're very extreme and you have underlying health issues, are going to kill you. And then we have CO2 buildup to consider, and also other off gases. And typically these aren't that dangerous in a dental practice. And then we've got particulates, and this is really where we as dentists and hygienists and dental professionals, even everybody in our office that are chronically exposed, these are the things that we need to consider and look at. Aerosols, when we talk about aerosols, and I'm going to mention a couple of the studies here in just a few minutes, but almost every procedure that we do in dentistry generates some type of aerosol. And when we talk about aerosols, we really talk about particulate matter in the air that's less than 50 microns in diameter. Things that are larger than 50 tend to settle out and they don't stay suspended. And then when we look at true aerosols, they get down below 10 micron particle size, and those stay suspended for maybe 100 hours or longer. And they'll spread throughout your entire office. So they stay suspended, and we are continued to be exposed to them. Shortly after the development of the dental high-speed handpiece, which I think, for all of us, is just, was part of our entire career, and that was normal. But, it really developed in the late 1950s, and it was really about mid-1960s when it was first incorporated into dental schools and then into dental practice. And it was quite controversial at the time. People were worried about it, causing damage to the teeth and killing pulp tissue and what have you. And they added the air and water spray to it to help cool the teeth. And at the same point in time, that created this aerosol. And the first paper really that was published on studying the aerosol was by Miller and Missick back in 1969. And what's interesting to me as I look at this, they considered aerosols to be 50 micron size and less. And the thing that I found interesting is that the thing that generated the most aerosol, if you look at the chart here on the left, coughing, obviously 36 particles, sneezing 500, but brushing your teeth actually created, 2,500 particles per cubic meter just from brushing your teeth in terms of creating aerosol. And probably like some of our sonic or electronic type toothbrushes may even generate more than that. But I thought that was kind of interesting. In my mind, the study that I think was really the landmark paper on dental aerosols was published in 2004 by Harrell and Molinari. And they really looked at the generation of aerosols, the causes of aerosols, types of diseases that are, we know are now spread by aerosol, and then what we might do to mitigate our risk in some of that. This is kind of interesting when we look at this, pneumonic plague, obviously that's not something that we tend to think about on a daily basis. Tuberculosis, however, it wasn't until probably 2 decades ago that we realized and discovered that tuberculosis is actually spread by aerosols. Up to that point in time, they really thought it was spread by contact and droplets and mucus. And now we know that tuberculosis is spread by aerosols. And while tuberculosis isn't the disease in terms of commonality that it used to be, we've got a lot, we have a lot of outbreaks every year in the United States of tuberculosis, and primarily from immigrants from Central America and South America. So we've got tuberculosis is still around, and it's still something for us to deal with. Influenza, we've been dealing with influenza for 100 years, literally over 100 years. I had a cousin die from influenza this year who was a year older than me. Locally, and had his flu vaccine, and yet so influenza, we still lose people in the United States every year to influenza. And then you've got the SARS obviously is the big one, and certainly COVID at this point in time. And I'm going to talk about that concept as well, because there's been a lot of debate and I think confusion and uncertainty on whether COVID was spread by aerosol or not. And then they brought up in this paper, they brought up the different technologies, and certainly we recognize, and right out of the gate, you think about the high-speed handpiece, the ultrasonic handpiece, all these obvious things that create aerosols. But the interesting thing is that like the air-water syringe creates, every time you hit both of those buttons, creates an aerosol. That's what it is an aerosol, and it's actually the fastest velocity aerosol that we create when we're working on patients. So, I mean, you've got air polishing, air abrasion, the hard tissue lasers that produce an aerosol as well. So you've got a lot of technologies. Literally, anytime we sit down and work with a patient, we run the risk of generating an aerosol. And then, how do we protect ourselves against that environment? And of course, then, the obvious stuff, the PPE that we've been using for, almost 35 years, masks and gloves on a routine basis. Of course, now, since COVID, we've gone to the N95 mask and face shields and, hair covering and gowns of sort and what have you. And I think it's appropriate for us to think about this. Maybe this is a new standard in terms of PPE, kind of long term. I don't really see us going backwards on this. One of the other things they brought up in this study that I mentioned briefly at the start was the use of a pre-procedural rinse. And I'd encourage you, if you're not doing this, this is one way to reduce the contamination in the aerosol from a patient for about 30 to 60 minutes, is to have them use one of the recommended agents, that we know are effective against COVID. And it is effective at reducing up to, like 58 to 60% of the microbes in their mouth, and they then get released in the aerosol. Obviously, we're all using high volume evacuation, all the time, but it's really challenging for like a hygienist. And I think that's why they're at risk so much is, they typically work by themselves. And if so, you've got a high volume evacuation in one hand and you've got the ultrasonic handpiece in the other. It's really hard to control that aerosol, even the spatter when you're doing a prophy, when you're working by yourself without an assistant. And then the last thing they mentioned was a high efficiency particulate, HEPA room filter, or, in my mind, a better yet protocol would be an extraoral filter that captures the aerosol, as it leaves the patient's mouth. When we look at specifically types of aerosols and the sizes, if you look at this chart, the smaller, the aerosol, the more likely that they stay suspended, as I mentioned earlier. And also, the smaller they are, the more likely they're going to get into your lung tissue, into the alveolus. So bacteria, they're in that 10 to 1 to 10 type particle size range. Most of those things we have control of, but you get down into the virus particles, and like the COVID virus particle is 0.12 microns. Now, you don't have a lot of naked virus particles in the aerosol, but they do exist there. But you get those aerosols below 10 microns, and they stay suspended. If you look at the research for, the smaller they are, the longer they stay suspended in the air. So aerosols typically can, consist of particulate mixed with water droplets of different sizes. So we have this variety of sizes, and particularly when there was just a study that was published last month, looking at the size of the droplet, the particle, and the infectiousness or contagiousness of the COVID within that droplet size. And when you got, the smaller you got, the more infectious it became. So it's like it was more contagious, like the smaller the droplet size. So it's very important for us to think about the fact that when you get below 1 micron, those are suspended in the air the longest, but they're also the most infectious. And they're also, you get below 7 microns in size, and this is a critical number. You get below 7 microns, and that actually gets past all the barriers, in your body, and they end up in the alveolus, and ultimately your lung becomes the ultimate filter for that. So that's one of the challenges that we have. Another thing that we're all utilizing, of course, I just came from our CariFree Christmas party today, and people, I took a picture of it because people are sitting at each end of a table, 8 feet apart, spread 6 feet apart in this, it's, and everybody's wearing a mask, and we've got HEPA, air filters at each table, and it's like, how much more festive can you get, right? But that's kind of where we're at today. And we know social distancing does work, particularly for droplets, not for aerosols, but for droplets. And, the question is like, well, where does that research come from? Well, it's interesting. It comes all the way back from 1897, where it was first published. And they determined that droplets like that 100 micron droplet size and larger actually drop out from gravity and air surface tension, drop out in the first 1 to 2 meters. So basically, if you're 6 feet away from somebody, you're not going to collect those droplets. Now, on this chart, this was a study that was published again earlier this year. They went through a chart and they took the scenarios. And if you start at the upper left-hand side, you're outside, you've got great ventilation, you're not very close to people, there's not very many people there. It's the woman lying on the beach by herself with a mask on. Her risk of catching COVID is non-existent. Then you progress all the way diagonally down to the bottom right-hand corner. You're in a small room, it's a crowded room, and you don't have very good ventilation, you don't have isolation, you don't have social distancing, nobody's wearing a mask, and now you've got a recipe for disaster or a huge transmission of this disease. We talked about, I mentioned just briefly the concept of COVID being transmitted by aerosol, and there's a number of studies. I'm going to highlight one of them, but one of the things that came out was, if you guys remember the report earlier this year, the church in Skagit County, Washington State, where they had 61 choir members were at choir practice all together. I mean, in the choir pews, crowded together, singing, which we know produces, shouting or singing produces even more aerosol. And 53 out of the 61 people, that was like, a super spreader event. 53 out of 61 of them became COVID positive from one individual. And the only explanation for that, the only model that explains that amount of infectivity is spread by aerosol. So while we don't have a lot of science, to support spread by aerosol, those studies take a long time to develop and produce. And so we're not going to see those for quite a while. But I think most of the experts around the globe at this point in time, while there was some maybe some confusion or disagreement earlier this year, I think everybody at this point in time firmly believes that COVID is spread by aerosol. So that brings us into play, because we probably generate more aerosols than any other job that I can think of. And again, we talked about that critical, 7 micron size is kind of your natural defenses in your nose and your mouth, where you're going to, stop those droplets. But when they get below 7, they actually pass into the lung. And again, we know the smaller those droplets are, the more infectious they become as well. And, in the alveoli, that's where the oxygen, carbon dioxide change takes place. And it's also where this infection starts. And that's why you get the acute, respiratory, syndrome from this is that it starts in the lung, starts in the alveoli. And if you have people that are susceptible or have other underlying conditions, certainly get this huge inflammatory cascade in the lungs, and that's why this disease becomes so fatal so quickly.
It's interesting, the trust factor, because, you know, we have patients, and so do you, who come in every day and say, this is the first big outing I have. I was so excited to be here. We came because we really trust you. Dentistry has earned that trust. I certainly hope that I have with my patients by taking this very seriously, not today, but always. I was involved in the HIV infection, the bloodborne pathogen standard formation in the 80s. And integral to that was taking a really good look at splatter back then, by procuring standards that allowed us to continue to work through that crisis. Means that we were left with masks and gloves, and barrier protection forever. And in that process, we drove down lots of other pathogens that were spread by aerosols too, like hepatitis B, which was a bigger risk factor at the time than HIV in terms of numbers, not severity. But also things like ocular herpes and staph and strep and other things that dentistry had suffered with for a very, very long time. So if you look at dentistry compared to medicine, I recently was at the doctor. It doesn't matter if you're in for a dermatology appointment or a gynecology appointment, they typically just roll the paper down the table, and that was all they did. We were way on top of this, which is one of the things that has kept dental offices from being contact spreaders throughout. And yet, of course, the risks are higher here because of the procedures we do. And in a little bit, I'll talk more about those procedures and what are some of the things that you could do to mitigate aerosols, starting with not brushing your teeth in public, obviously, as we saw from the last slide.
Susan, you bring up a really good point, though. I want to go back to that for just a second. Is that I think patients feel safe. Like as far as I'm concerned, the safest place you could be in the world right now is in a dental practice, right? In terms of it, we still got the aerosol. We've still got but as somebody going someplace, certainly a lot safer there. And I'm really proud of our profession that we took this issue so seriously, so quickly, of course, because I think we had that experience, Susan, with your help back in the 1980s with HIV, that it's like, we were already doing so much and we're so aware of aerosols and that transmission of disease in our practice. But, one other thing I didn't mention, which I'd throw out here too as well, is HPV. I've got several colleagues who have HPV throat cancer. And I have to tell you, we have a disproportionate number of dental professionals that have oral cancer from HPV. And I can't help but think that that's coming from the aerosol as well. So there's a lot of issues here that COVID brought this topic up. And I think it's a topic that I hope we continue this conversation, because I want us all to be safe. I don't need any more emails finding out that some of my colleagues have died from IPF, because this is totally preventable. We can completely control the aerosol. And we'll get into that. Talking about the aerosol spread, then, this was a paper that was just published literally last month, like 3 weeks ago. And if you really, it could be this paper literally could be a textbook, but they look at all the study designs. They looked at all of the computer modeling. They looked at this inside and out. It's one of the most detailed studies that I have read on aerosol transmission. And the interesting thing is that they're in the abstract, they state that we don't have hard scientific evidence that COVID is spread by aerosol. And then they spend the next 40 pages and about 250 references explaining how the aerosol transmission is the only way you can explain this disease. While we don't have the scientific evidence, it's like, then they build the argument for it. It has to be by aerosol. I mean, literally, that nothing else explains it. So if you want to read a really good paper on that, you'll have to subscribe and buy it. But it's really well written. It's just this whole concept of, we create the aerosols by breathing, coughing, sneezing, singing, shouting. Creates the aerosols. Obviously, I'm in a room by myself here, so I'm not wearing a mask. But then, we have the technologies that create aerosols in our practices as well. And again, things that we just don't even, stop to think about, the air water syringe, maybe. And again, I'm gonna, again, 7 microns is a critical number here for everybody to continue to be aware of. Dr. Fauci, I think, has been a great leader this year, in terms of trying to, our CDC is some of the best scientists in the world. And even they were stumped and struggled through this pandemic. And so I think we all need to be a little patient with each other. This was a novel virus. And so, it took us a while to learn, how to deal with it, what things were effective and what things weren't. So we have CDC guidelines that come down, from the CDC. Here's what you can do or what you should do is recommendations in a dental practice. And basically, it's use all the PPE that you can, and then reduce your exposure, reduce the use of aerosol generating technology as much as you can, do minimally invasive, procedures, and, reduce the aerosols as much as you can at the same point in time. The ADA is going to be a theme here on all these recommendations. Again, the same thing is try and reduce the production of aerosols as much as you can, do hand instrumentation. And, I think hygienists are bearing the brunt of this, not being able to use ultrasonic handpieces this year. Trying to do all that, periodontal therapy with just hand scaling alone is, we're going to probably see an outcome of an increase in carpal tunnel syndrome from our, the hygienists in the country.
Can I
And
say
then we've
that
got,
for a moment? I think one of the things you left off that list was polishing teeth. And what's really interesting is that we know that there's no real efficacy in polishing. We've been teaching selective polishing for many, many years, and yet a lot of people don't practice it. The idea, my hygienists don't polish anyway unless they're stained. That's the indication for it. We leave healthy biofilm. But when they do polish, they need some help. So for a while, until we were able to use the DACs, we were not able to polish or use ultrasonic scalers at all. And I think that's critical. It did allow us to slow down and help the patient learn how to better care for their own teeth at home, which may be a better use of your time than getting out your ultrasonic scaler or polisher altogether, right? Is
right.
to really go back to basics and say, let me help you learn how to deplaque daily so that we can address this together, as long as we're not able to use some of our fancier equipment. But I think the polishing is a point I like to make, because I still think in dentistry, even though we know about selective polishing and we've heard that it's not effective and especially not helpful at all with baby teeth, especially, we keep doing it. I'm not quite sure why. This is a really, really nice time to explain to patients that there's no efficacy in polishing. And if we're going to polish, we need to do it in the safest manner possible.
Yeah, we really need to start thinking just about calculus and stain removal and quit talking about polishing.
Right.
And that's a whole nother hot topic. That would be another great topic for the co-op, for one of these webinars, because that's certainly the science supports that. And again, the challenges we've got there. Same thing, OSHA again just brings up the same guidelines, and then each of you have your own state health authority, which has their own guidelines. I know, Susan, you're in Michigan. Your governor, like my governor here in Oregon, tend to be rather extreme in some of the recommendations,
yes,
in my opinion, but that's where we are. But so we have the state health authorities, and which provide guidelines for us as well, which we have to adhere to. So what do we do about that? Well, we started with the N95 mask this year, and I would tell you, it's probably the best mask that we have to use, not because it filters the best, because the class 3 surgical mask filters at 98%. But the challenge is you don't have the facial seal that you get with an N95. The N95 has the best facial seal, and so it's probably the most effective. There was a study published, however, in Canada in the Canadian Medical Journal 3 years ago, looking at the outcome, was looking at physicians wearing N95s versus class 3 surgical masks, and which of them, which was more effective at protecting the physician from contracting an infectious disease. And it turns out there was no significant difference between the two. So in terms of aerosol-borne diseases. So I think the N95 or KN95 wins out on the facial seal, but I think when it comes to the filtration, and certainly a class 3 surgical mask is probably a gold standard. And then we also know that we just have limited these other studies. This was from last year. We know that N95s, have just limited capability of filtering everything, and particularly among particles that are 1 micron in size or less. Again, those are the particles that we're most worried about. Those are the airborne aerosols that are going to get into your lungs, and we also know at this point in time that those are the most infectious of the droplets or aerosol sizes as well. So there's different things that we can address in our practice to help protect ourselves. One of them is UV light. You can buy these small units like on Amazon. You can get a small, UV light to sterilize your cell phone, sterilize your operatory surfaces, that kind of stuff. Obviously, UV light damages your eyes, so you don't want to be in there while you're doing that. But again, you can use UV light to disinfect some types of surfaces. It takes generally 10 to 12 minutes with most of the wattage, that we have on these small units to be able to create some level of, infection control. It doesn't meet the CDC, ADA, OSHA guidelines, but we do know that it does work, and it's not going to get rid of aerosols. But as aerosols land on surfaces, you can certainly use it to disinfect some of those surfaces or some of the instruments, like your cell phone or whatever. But the challenge with UV light is the kill rate is just so slow. It takes seconds to minutes to actually get a very effective kill rate. And when you use these, air filters that have the UV light in them, typically their exposure of the air is moving so fast through those filters that the UV light really doesn't have an opportunity to promote any significant level of disinfection. So again, that's not something that meets guidelines, but UV light, but it's something that you can use to. I would say UV light could be used to disinfect surfaces or small technologies that you've got in your practice. Then you've got air purification filters, and these are little units. We actually have these in our building, and people have them sitting at their desk here at CariFree. I know a lot of people have bought these and put them in their operatories. And a HEPA filter, high efficiency particulate air, by definition, traps 99.97% of the 0.3 micron particles. And I'm going to talk about that because there's some confusion, and there's a lot of confusion, and let me say there's a lot of disinformation that's out there as well. But so it does clean the air very effectively. It's a good thing to have. The problem is, it's not capturing the aerosol when it leaves the patient's mouth. Once it's in the air and after it's in your breathing zone, yeah, you can reduce the overall particulate of matter in the air in your operatory or in your office or wherever. But in terms of capturing the aerosol, you're still breathing it. Your staff is still breathing it before it has an opportunity to get to that. And one of the studies that was done on that was published back in 2010, and they looked at these small units in an operatory, basically looking at the dental healthcare worker and their exposure to the particulate based on the positioning of the small air purifier. And what they found was, and it's like this is not rocket science, but what they found in the study, which was very well done, what they found, the closer that they had it to the patient's mouth, the better it was, right? So, I mean, this really points to the thought of, well, we really need, these are great, and surgically clean air, if you're gonna look at these, in my opinion, is probably the best on the market. But I know in their independent studies, they've demonstrated they reduced the particulate in the air in an operatory by 85%. They've had some great studies on that. But at the same point in time, you're not capturing the aerosol where I think we really need to do. I want to get the aerosol out of your breathing zone. So, and that's based on that study as well. The intraoral aerosol suction systems are great. There's a number that have of them that are available that have all kinds of different attachments that are either disposable or autoclavable. Some of them have lights, some of them have mouth props, some of them have all of that. They do a great job on splatter. They capture some of the aerosol. So if you use that, I think that's a great addition. It's a great instrument. But again, we're talking about fairly low air volume. And again, if you don't maintain them really well, you've got a challenge with it that reduces their capability as well. And they just have limited vacuum coverage. So, those aerosols are traveling fairly rapidly out of the mouth. So again, those are things that, they work well on particles or droplets above the size of 10 microns, but below 10 microns, those particles escape the mouth. And again, you get down into that 7-micron zone, and now we're talking about something potentially that would get in your lungs. And if it's below 1 micron, potentially going to go right through your N95 mask. And we know that that's the most infectious sized particle. So something to just be aware of. We all are going to be using an HVE of some sort. That's a given. But again, this isn't something that's a complete answer in terms of controlling the aerosol. It controls the droplets, pretty well, but not the aerosol itself. So, we come to extra oral aerosol, vacuum systems. And again, I worked on this technology 25 years ago. I understood the technology, really well. So I sat down earlier this year and thought, okay, if I could design one specifically to protect the dentist and the hygienist and the assistant from a virus-sized particle, what kind of criteria would it need to have? And so then I looked at those criteria and then worked on that design from there. Again, most of these that are available have a HEPA filter, which again, by definition, 99.97% efficient at 0.3 microns. That's the hardest size particle to capture, as it turns out. And there's different physics behind that, and we'll talk about that, those physics, because I think that's where a lot of the confusion comes in. But there have been a number of studies. These studies go back over the last 20 years. A lot of them come out of Japan. But the studies are all consistent. Using an extraoral high volume evacuation really reduces the amount of aerosol, the amount of exposure to the dental healthcare worker. And I mean, it significantly reduces their exposure. So this is something that I think for us going forward, not just because of COVID, but because when we talk about IPF long-term, which is the real story here in my mind, you don't hear about dentists right at the moment dying from COVID, being exposed at the office, but I got to tell you what, our colleagues are getting sick and dying from IPF. And we've only really come to recognize this in the last 5 years. And so I think you're going to hear more about that. Again, this conversation is long overdue, and I'm really happy that we have so many people here today that are actually sharing this webinar with us, Susan. One of the things about that high volume evacuation, if you look at this chart, this study was published, and looking at droplets and capture rate, and again, looking at the droplet diameter there on the x-axis, from 1 micron up to 10, you're only going to capture about, best case scenario, 40% of those, and most of those you're going to capture somewhere between 30 and 40%. However, when you combine that intraoral suction with an extraoral vacuum, you get capture rate up into the 90%, 90+% rate, particularly in that set critical 1 micron particle size and 7 micron particle size, which get into the lungs. So again, there's just been a number of studies. This is one that recommended that this was published earlier this year. Not only do we use high volume evacuation, but we should also be using extraoral HEPA vacuum as well. So Susan, I can't tell you how much I enjoy having you as my co-presenter today. You and I've been friends for a long time, and you're a phenomenal clinician, and you have my greatest respect. And so I just wanted you to share with today a little bit about you're using an extraoral vacuum, you're using some of that technology. What's your perspective as a dentist? What are your hygienist perspective, your assistants, your patients? I mean, what do your patients think about that? And then what kind of influence do you think that has on your market as well?
Well, I'm going to start with my perspective as a friend or loved one. I feel like most of our patients are well protected because we're protected with good mask wear. One of the questions came up in the Q&A, what about men with beards? Are you really protected? And I would say probably not. You're not, the better the seal, the more you protect other people from the mask. People sort of don't get the mask concept. I loved the little meme that had 2 guys standing drawings naked and the ones, and it says, so here's the deal with the mask. If a guy stands next to you naked and pees on you, you get wet. If you're wearing pants, you get less wet. If he's wearing pants, you don't get wet. Do you get that? Okay, now it's a little naughty,
Yeah,
but
I do totally.
yeah. So the point of the matter is if we're wearing masks, we're protecting our patients, and yet who's protecting us? We cannot work without having people take their masks off and blowing air and water into their mouth and creating an aerosol. So my first responsibility is to my loved ones, which are my team members. If I feel like I can adequately protect them in their day-to-day work and make them proud that they came back to work during COVID and that they're feeling safe and confident in their ability to care for patients without taking risks to themselves and their own family members, I'm doing a really good service, and thereby I'm also protecting my patients and their families. So I worry most about my team members, which means you said you're so proud of dentistry. I'm proud of dentistry too, but we're not all doing it the same. So it means that we hold each other accountable to say, hey, this is what we committed to. Let's stick to that. I'm still hoping that we're chasing this. We're either going to get immunity from a virus or vaccine. And I'm hoping we make it to the finish line and get the vaccine without getting sick. And that's my first responsibility. So yes, I believe that the pre-rinse, I tell the patients, thank you for doing this. It's to protect us from early shedders. The air filtration that goes right behind the patient's head. We're using the molecule, which kills on a DNA level, but right behind the patient's head. Does it make good sense? Is it really great for patients to see this? Is it a good marketing thing? Absolutely. But really what I want to make sure is it's as close to my dental assistant and myself as it can be in back of the patient's head. So close. And then we waited with bated breath to get these. We've affectionately named it. Everyone said it reminded us of Dr. Seuss. And I was like looking at the Cat in the Hat with that great big, picker-upper that they drove through at the end. But then I'm like, no, one of my patients said, it's Horton. Horton, here's a who. So now we've named this guy Horton. And oh, look, it even sucked up our elf.
The elf stood a little too close to the extra vacuum there today.
Sometimes it will suck my hair right up if I'm not tied back all the way. We're laughing at that, but it's very, very important for me that whenever we're using air water syringe, the high-speed hand pieces, or the laser, that we have this right up next to the patient's face, helping us feel a lot more confident. So I think patients are very excited to see technology. Again, we're charging $10 to each patient for each visit, which doesn't sound like a lot. It's not a lot compared to what we've spent in terms of trying to upfit this. But
so Susan, you can sit literally and watch all the aerosol actually being sucked out of the patient.
Oh yeah. Oh yes.
And so your face shield and everything are clean at the end of a procedure.
It's amazing.
Yeah. So the question I got for you, after COVID is over, you've had the vaccine and we're not worried about it anymore, are you going to continue to use an extra-oral vacuum?
The answer is I have not had to make that decision. My team members clinically set it up with every patient, and I would guess 100%. I mean, as a leader, I would say yes, but I would guess they want that. They know the difference and they feel the difference. And I think we're going to measure COVID in years, not months. I think it's going to be a long while before the public has access to the vaccine. And I think it will be important for all of us to continue.
Yeah, and it may be like influenza. It may be something that we learn that we have to live with. And I think I appreciate your answers on that, because I consistently hear that from dentists and dental teams and hygienists particularly that are using an extra-oral HEPA vacuum, that they're controlling the aerosol and they're not going back. Like, it's like, why would you? When you see what you're missing in terms of you're not breathing this stuff anymore or wearing it, why would you go back to that? And that's why I think this conversation is just so long overdue. So
patients love it. They say, wow, that's really cool. They notice that we've really gone extra steps to do that.
Yeah, I know the patients appreciate that as well. These are actually, I took these measurements myself. So one of the questions I had as I was designing an instrument was, well, how fast does the vacuum have to be? Because back in the 90s, I was designing a vacuum just to capture, air abrasion particles, which were 27 microns in average size and not traveling that fast. We were using, 60 to 80 PSI. And so they were, in terms of particles, that was the layup. I mean, those things are easy to capture. So that was easy to control. When we start looking at virus-sized particles, and when I say virus-sized particles, I'm talking about then also those pieces of bacterial protein that I'm concerned about, because it really, in my mind, I don't get emails of my colleagues dying from COVID. I get emails of my colleagues dying from IPF. And I think that's the real story here. And if you haven't heard of it before, look it up. I want you to go educate yourself, because we can protect ourselves literally almost 100% against that, and probably protect ourselves from, HPV and everything else that you can name at the same point in time. But I measured these clinically, and to my surprise, the air water syringe produces the highest velocity of the aerosols. It comes out of the patient's mouth at 45 miles an hour, which means that I don't care what your cubic feet per minute are. If you don't have at least 50-mile-an-hour velocity suction, that's going to go right on by. You can be sucking 200 cubic feet a minute, but if it's not at the right velocity, those particles go right on by. I mean, it's going to capture some of them, but you're not going to capture all of them. So the high-speed drill and the ultrasonic scaler, they run around mid-30s. So you really, when we talk about air velocity, you really want to have, it's not just CFM that you need to think about when you're looking at an extraoral unit. You really need to talk about velocity. CFM is important, and you want to have somewhere around, I would say 120 at the bare minimum, up to at least 200 CFM to be able to capture the volume of aerosol as well, and splatter and those heavier droplets. So it isn't just velocity, because the high volume evacuation is running at about 80 miles an hour. The problem is it's only, a centimeter in diameter, so it only has like 5 to 10 cubic feet per minute capacity. So again, some of that air, that aerosol escapes past it. So it's kind of a combination of both. So you want, you need to control the dental aerosol somewhere in 120 to 200. The higher or the greater the aerosol being produced, like particularly like with either a high-speed handpiece or the ultrasonic handpiece, you want to be closer to that 200, but you also want to have a velocity somewhere around 50 miles an hour. When we talk about HEPA filters, and I, again, this is technology that I understand, and so I saw a lot of talking to dentists and stuff earlier this year. I saw a lot of confusion here, and the standard for HEPA, high efficiency particulate air, is that it captures 99.97% of particles down to 0.3, which is the hardest particle size to capture. And we'll talk about the physics in just a minute, because I want you to understand this. So down to 0.3, that's captured by the pore size of the filter, the HEPA filter media. So if it's bigger than 0.3 microns, that's captured by the filter. It just won't get through. If it's smaller than 0.3, it passes on through. So how do you capture those? Well, NASA worked this out. It's a very specific velocity. NASA research worked it out. If you slow the air velocity, then going through the filter, 50 miles an hour here, and then to the filter going 0.06 miles an hour through the filter itself, you'll capture 99.995% of those particles down to 0.01 microns. So down to 0.3, that's driven specifically by the pore size and the filter, and below 0.3, that's driven by velocity. And so it's really important that we understand that. So those two things are, when you talk about an extraoral vacuum, with two features, the only two features in my mind that are critical and matter: how fast is the velocity at the suction, because it needs to be at least 50, and then how slow is it at the filter, because it has to be 3 to 5 lineal, the window is 3 to 5 lineal feet per minute, which works out to about 0.06 miles an hour. So that becomes then how you figure that out as a function of the air velocity, the cubic feet per minute, and then the square footage of the filter itself. When you talk about HEPA filter ratings, and these are all over the board because we've got different standards. And the MERV standard, which you're probably all familiar with, and I heard a lot of that, it's got to be MERV 16. I'm going to buy a vacuum, but it's got to be MERV. That's for HVAC system. That's for your heating and air conditioning system. MERV is for heating and air conditioning. So talking about MERV, in an extraoral vacuum, you're talking about apples and oranges. The European standard is the H standard, H1 through H14. H14, 13 and 14 would be like a hospital room, isolation type room type standard, 99.97%, 99.99. And then they also have the OPA filter rating, which is a step higher. But the American rating, and this is the one that I think is most valuable to us when we talk about, freestanding extraoral units, is the American Society of Mechanical Engineering and the Department of Energy standards. And in that, so I picked I picked a filter that's custom made. It's a 99, it's a class C, 99.99% efficient down to 0.1 microns. So that's a filter that I would recommend. If we look at that velocity, what I was talking about, in the middle of this chart, if I've had Dennis send me this chart, I was like, I don't get this, I don't understand this. Why is it that you can't capture that 0.3 and then you can capture those on the left side of that as they got smaller? Well, the right half of that graph, again, is based on the filter. The left half of that graph is based on the velocity of the air going over the filter. So it can be very effective, but again, it's got to be a very specific window. And that, I don't need to get into some of the physics here. If you want to, we can.
We can.
I'm happy to explain that, but just say that the diffusion effect based on the velocity occurs because of Brownian motion, the random motion of those little particles. They have to be traveling slow enough to actually bump into and then adhere to one of the fibers in the filter. And then there's electrostatic forces like van der Waals forces that take place as well. But they can be, but the point I want to make is HEPA filter can be very, very, very efficient at removing virtually almost 100% of virus-sized particles, but it's dependent upon the velocity. And so that's something that we all need to be aware of.
Dr.
When I looked at systems that were on the market, so I have two sons that are dentists, and I wanted them protected in March. And I have a partner and two associates that I want to protect it, and then I have colleagues and very, very close friends like Susan that I want to protect it. And so I got my team of engineers together, and we sat down and looked at this as how do we solve this problem, and how do we take the leverage the NASA science to do that. And what I found, typically the vacuums that are on the market, their velocity is somewhere around 25 to 40 miles an hour. The volume is somewhere around 80 to 200, maximum. And they have the 99.97, 0.3 microns. I couldn't find anybody that even knew what the velocity of their filter was. Didn't even know that was an issue or why it would be an issue. And then, of course, noise is a concern. You can design anything, but if it sounds like a jet engine going off in your operatory, that becomes problematic as well.
Hey, Dr. Kutsch.
Yeah.
Dr. Kutsch, I'm so sorry to interrupt you, but we are at time.
I see that, and we are on my last slide.
Oh, are we? Okay, finish up, and then we'll get to some of the questions.
Yep. So, the last thing I want to leave you with in summary here is that dentistry is a high health risk profession. We're using aerosols. These are problematic. It's really not just about COVID at this point in time, but it's also about IPF, and you're going to hear more about that in the future. And I think that the best thing you could do is use a pre-rinse, pre-procedural rinse for every patient, for every procedure. And then add both your intraoral and an extraoral suction system is the best way to protect yourself and your teams in terms of controlling the aerosol and having the best, the cleanest and safest air in your operatory. So that was a lot of information to load on you in 1 hour, but I appreciate everybody being here, going through this with us. We've got time for, let's take a couple of questions, and then I want to talk about, we'll give the course code, and then if you want to stay on for another 3 or 4 minutes, I'll talk to you a little bit about the unit I designed. So let's grab some questions.
Great. Excellent. Thank you, Dr. Kutsch, so much. And yeah, like Dr. Kutsch said, we'll be popping the code up for everybody here. So you can get that just in case you need to head out. But in the meantime, we got a lot of questions, Dr. Kutsch. So we'll just take a couple. And the first will be from Sarah. And she asks, if extraoral HEPA filters are so effective, why do hospitals have much more stringent protocols to contain aerosols and airborne diseases?
Why don't they?
Why do they?
Why do they? Well, they have the ability to isolate patients that are infected. So I guess that's the best way I would answer that. We don't have the opportunity to have an isolation room to put your patient in, where you've got laminar flow air, and we don't have the opportunity to do that. I mean, if you wanted to design a hospital suite for a dental operatory and have laminar flow air, you'd be using an H14 filter, which is the equivalent of the filter basically that I would recommend that you'd use in an extraoral vacuum. So it's really a function of, you need for a dental practice, you need a portable unit that you can use, pull in and use, short of replumbing and redesigning the entire, essentially creating a clean room out of each operatory, which would cost about $250,000 per operatory. So that's why hospitals do that.
Got it. Got it. Excellent. Thank you for that. And we'll just do one more, and then you and Dr. Maples can do a little bit more chatting if people want to hang on the line. Someone asked, how do you sterilize the extraoral suction?
So how to sterilize it?
Mm-hmm.
So I guess the best answer to that is you can wipe it down. You can spray it, wipe down the exterior surface. You can spray at least the inside of the cone. Beyond that, the hose, it's like the hose on your high volume evacuation. You can certainly spray that down as well. The filter needs to be replaced probably 1 to 2 times per year. And I would say, let's talk about disinfection. Like you're not sterilizing your x-ray head, you're not sterilizing your chair, you're disinfecting them. But literally anything that gets trapped in that filter is trapped, and the filter is not coming out the other side. So I guess that's the best, at this point in time, probably the best answer I could give you.
Great. Thanks, Dr. Kutsch. And because of the time, we're going to hold off on the rest of the questions. But if you're still on, just know that we will get them answered and send the answers out to all the Q&A in our follow-up email to this webinar. So be looking in your inbox for those. And now I will just turn it over, Dr. Kutsch, to you and Dr. Maples, if you'd like to continue your conversation.
Yep. So the CE portion of this class has ended. Now we can talk about, I can talk about the design basically that I worked on this year. Let me go back to here.
You want to give the code, or did you already do? Yeah,
yeah, the code was already up. Hopefully everybody got that.
Sorry, Dr. Kutsch. For everyone listening, the code was the COOP 30, THECOOP 30, and enter that on your CE Zoom account. Thank you so much.
Yeah, thank you. Thanks, Sharon. So, one of the things that I sat down with my team of engineers back in March, I looked at this technology, and again, like I said, I wanted to protect my family and my friends, my colleagues and friends. And this is what I do. I mean, I've been building, designing dental products for 30 years now. So, and I guess fortunately or unfortunately, I happen to have expertise in this area. And so I sat down with my engineers I've worked with for 20 years, and we laid out, and quite frankly, I took the NASA science, and we weren't certain we'd be able to accomplish that in a portable unit. And actually, we beyond accomplished it at the end of the day. So I'm really pleased with that. So we have maximum airspeed of 57 miles an hour. We have an air volume of 230 cubic feet per minute, which was actually honestly tested. A lot of things I'll see reports, but we've actually tested some units on the market, and their let me say their actual CFM didn't meet their advertised by a significant amount. So we actually test with scientific meters, all this stuff. We have the HEPA filter that we had custom designed and individually certified at 99.99% capture rate down to 0.01 microns. And then the air velocity, and this is critical again, is 0.06 miles an hour. The noise level runs on low from about 63 decibels, which is about background noise in an operatory, to 73 decibels. To kind of give you a feel for that, the high-speed handpiece with high volume evacuation running runs at about 83 decibels, which is kind of on the borderline of the OSHA window in terms of allowable long-term 8-hour exposure, which is why so many of us dentists have hearing loss after 40 years of being chairside if you haven't protected your hearing. So this is the unit that I designed.
This is, by the way, it doesn't whistle like a high speed either. And you have a little remote. So when you're, as soon as you're done using aerosols, you can just push it and give yourself some relief. There is a little bit of noise, but it's not irritating. It does also create a little bit of a coolant effect. So those of you who are really warm working, feel like you keep the office comfortable for patients, but now you're gowned up and you have another gown on top of that for, it's kind of nice for people that feel like they're warm all the time.
And it also has a removable and reusable shield, a clear shield you can see just above the orifice there. And like Susan said, it comes with a remote control, so you can control it easily. It has 4 different presets at the moment, and you can turn it on off. And I would actually let it run all the time on low just to continue to filter the air in your operatory and continue to clean that. So if you want to know more about the unit that we designed, you can go to dentalsafetyfirst.com. If you want more information, you can email info@dentalsafetyfirst.com. If you want to place a phone call, if you have questions, you can dial 541-371-2760. And I just wanted to share with you, I got my team together, and there's a special, there's a coupon code if you decide to purchase one of these units. There's the coupon, the code is all uppercase letters, DAXCOOP12. That entitles you to a $200 discount. And if you order before December 20th, you'll get an extra replacement filter, which is a $195 value. And so if you haven't used your tax section 179 this year, this might be something that you want to invest in. But I'd encourage you to look at this technology. Whether you buy this unit or any of them, seriously investigate idiopathic pulmonary fibrosis. Look it up, protect yourself. That disease is virtually 100% preventable. And this is a conversation we as a profession, we have been so complacent and so cavalier about working in that aerosol, that biological cloud. And I think it's really, COVID was the wake up call for us, but I think it's really time for us to have a serious conversation about that. Let's protect ourselves and protect our teams and protect our patients. So that pretty much concludes my presentation today. I want to thank you so much for spending your time with us. Hopefully that this was educational, informative for you. If I can be a resource to you in any way, please let us know. Again, I will try and get all of your questions answered. And I just want to thank you all so much for being here. And Susan, I want to thank you. You took time out of your middle of your day there in Michigan to be with us too. So, and I appreciate your expertise. And
I'm with you on this. I think it's a big message for all of us. And so spread the word to your friends. We're all happy to have dentistry taking a safer role in our occupation.
All right. So everybody have a safe and socially distanced holiday. And hopefully we'll get this vaccine soon. But again, we still need to talk about the aerosol. Thank you. Bye, everybody.
Bye-bye. Good. Did you like it?
Yes.
Good.
I thought that went very well. That's a lot of information again to give in an hour's time, Susan, but hopefully.
Well, I asked about hypochlorous acid. They asked about, there were some other good questions on there.
Good. Good. Yeah. So
Yeah.
excellent. Good. All right, Susan. Well, I'll be in touch.
Okay.
Thank you both.
Okay, bye-bye, everybody. Thank you.
Bye-bye.
Bye.
Thank you everyone for attending today. I'm going to read the verification code again. In fact, I'll share the slide. It's the COOP 30. And let me share this for you. Go on your CE Zoom account and log in. And next to this course, click the green verify button and enter this code right there. Click and enter it. And once your attendance is verified, your certificate will be in your records. Thank you and have a great day.